With this wonderful lecture, we move on ahead with our next lecture, Divide and Rule, Prosthdontic Planning of Hypodontia. Hypodontia, as we all know, is a prevalent craniofacial malformation and is a definite prosthodontic challenge. We are really honored to have with us Dr. Rajesh Patel, sir, who would be throwing more light upon this. To chair this session, we have with us Dr. Omkar Shetty, presently working as a dean at DY Patel, Navi Mumbai. Sir has completed his graduation and post-graduation from A.B. Shetty Institute, Mangalore. Thank you, sir, for joining us this morning. We also have Dr. Narendra Pariyar, sir, who is the principal and dean of Mahatma Gandhi Dental College and Hospital, the backbone of this convention. Thank you, sir. Sir has been the EC member of the Indian Prosthodontic Society since 2 terms. He's also the course director of the university with the postgraduate certificate course in implantology. And sir has an experience of over 25 years of teaching experience. And of course, sir is everything that you can see today. So thank you, sir, for being here. Over to you, sir, to introduce the keynote lecture, sir.
Thank you, Dr. Pragati. It's my pleasure to introduce the next speaker for today, Dr. Rajesh Patel. Dr. Rajesh Patel is currently working as a consultant in restorative dentistry at Charles Clifford Dental Hospital, Sheffield Teaching Hospital Trust. He is an honorary senior lecturer at the School of Clinical Dentistry, University of Sheffield. He is GDC registered with specialty in oral surgery, restorative dentistry, periodontology, endodontics, and prosthodontics. He works in various multidisciplinary teams, including orthodontics, implants, oncology, and pediatrics across all the floors of the CDCH, including special care, providing advice, support, and providing multidisciplinary treatment plans. He has many international and national publications to his credit. His topic today is Divide and Rule, Prosthodontic Planning for Hypodontia. So over to you, sir.
Thank you, sir.
Sir, you will have to unmute yourself, sir.
Okay, Alex.
Yes, sir.
Thank you very much for your kind introduction, and also to the organising committee for their kind, auspicious invitation to your conference. I understand that everything is delayed, and I'm so grateful that it's delayed because I had the opportunity to listen to the previous speaker, who was excellent, by the way. We are very fortunate here in Sheffield, in the UK, where we have orofacial teams who look at pain management. So when we have a problem in prosthodontics, we can refer to them quite easily. The pathways are already established. But he was actually a very good speaker. And for the postgraduates, all these experiences, and I've missed all of these in your conference because of the time. I wish I'd listened to all of them, but I can only share my experiences with hypodontia today. And I shall try and be brief and short, but the take-home message is always keep it simple. There is so much in dentistry available today that it can be overwhelming for the postgraduate student to try and be expert at everything. Although I'm a specialist in everything, I'm not an expert in anything, somebody said, because I'm just a general dentist. And the tools of the trade come from experience, and experience takes time. So I will share with you my experiences of what I've been doing at Sheffield. I've been there 24 years and 4 months, so I'm counting, but I've been qualified 32 years after training at King's in London and the Eastman to do a postgraduate degree in restorative dentistry. So moving on to the aims and objectives, really, hypodontia presents in so many different forms, much like orofacial pain. There are so many subsets of hypodontia, from a single missing tooth to multiple missing teeth. And I'm hoping that the postgraduate students today can understand that by dividing everything into smaller chunks, with the tools that they already have, they can apply a less is more philosophy and control a case from start to finish. Obviously, I'd like to be there in person. A lot of the cases I'm going to show are from my postgraduate students themselves. And invariably, they're not perfect, but hypodontia isn't a perfect science. They come with such complexity. So without further ado, I shall progress. But more importantly, I have had the benefit of working with lots of teams, including pediatrics, which I gave up 3 years ago. And I have a regular clinic with my orthodontic colleagues once a month to deal with all these patients and see them from childhood through to adulthood and beyond. I haven't included cleft lip and palate and ectodermal dysplasia. They're much more complex, but given the time, it's the tools and the application of the tools that are most important. I hope you can hear me well.
Yes, sir. You are absolutely clear.
Yeah. So, presentation. We have such a wide variety, and it can be the most common is the upper lateral incisor teeth that are missing, but invariably it could be one tooth that's missing. But associated with this is tooth size discrepancy, smaller teeth, conical teeth, arch size discrepancy. Some patients have lots of bone, some patients have very, very little bone. So the options of implants become much harder. The face heights can be reduced. And often the most common trait is the infraoccluded deciduous molar teeth and what to do with them. Altered occlusal planes don't help us as prosthodontists because we like everything even and clear and organized. And then you get the overeruption of teeth and altered occlusal planes, and it makes prosthodontics somewhat of a nightmare. But ultimately, a lot of these patients during childhood suffer with lack of confidence and anxiety over the appearance of their teeth. Because we live in a developed world that constantly markets, you've got to look good, you've got to smile good, and you've got to have the Gucci handbag and everything else. And despite this worldwide pandemic, I think people are starting to value the simple things in life: good health, good family, good friends. And I think I am hoping that this aspect of the COVID will have a positive impact to the well-being of a lot of our patients. I think attitudes and expectations have always been high. Thankfully, in our systems, hypodontia comes as a high priority, so they are available on the National Health Service, and generally funding for dental implants is not an issue because they're considered high priority. When I started in Sheffield some 24 years ago, each patient had to have an application for funding. So we could not provide any of the treatment without actually having funding approval. And funding here is probably completely different to the funding levels in India, because whilst we treat one patient here, you could probably treat 10 patients in India because the costs are so high. For example, it was something like £6,000 in 1997 to treat a full arch. And this is at base cost. This is not with on costs. So one health authority would provide us with the funding to do this. Now it's a little bit more, but just to give you a clue, in private practice, costs for a single tooth dental implant would be in the region of £2,000 to £3,000. And I suppose in India it will be a lot less, maybe a few £100s. The other issue about hypodontia is, can they consent to treatment? Because a lot of the treatments required are when they're younger. So I tend to do less for them to try and get them through. Often it's the gaps between their teeth that they're worried about. So a simple partial denture or perhaps some simple composites will help sustain them. How long will it last? Well, it depends on how long they're happy with it. Composites tend to stain quite easily, but they are the tool that all prosthodontics have. They're available to every dental practitioner. But the more long-term issue is, whatever treatment we do, the more extensive we do, the more we have to look after in the future. Because I've noticed that in these groups of patients that we do lots of treatment very young, they're going to have lots of recycling of treatment if they're not careful with their diet as they grow throughout life, go to university, get married, change jobs, move abroad. So the impact of these patients is quite severe, especially when they're missing lots of teeth. You will notice that I haven't got any references for you because I suspect you're all referenced out from, I've looked at the conference program, and I know that you have some fantastic speakers who have provided all the references. But for the context of this is all about planning. So measuring space is one of those issues that I have a constant discussion with my orthodontic colleagues. When they measure a space, they seem to measure the space with a ruler in a buccal position. But obviously, for us as prosthodontists, we have a three-dimensional position that we need to look at. And what can we do with this space? Sometimes with overeruption of teeth, there's a limitation of space or the wear of deciduous teeth, and we have to increase the vertical dimension to accommodate all of our prosthesis or crowns for the porcelain for the technicians. So common things are common. So measuring the space itself, if you look at the missing lateral incisor and you look at the actual incisor lateral incisor that's present, it's slightly buccally positioned, and you've got an asymmetric arch, and the posterior segment on the right-hand side seems to have shifted forwards, and you have an odd quadrilateral space. So from a prosthetic point of view, the path of insertion is guided by the contact points. The gingival margin looks good, and anteriorly the space looks good. But the tooth size, shape, rotations, angulations can make it a nightmare depending on what you're trying to achieve. So naturally in this particular case, if you look at all the local features, there is no contact between the canines. There's good space palatally on the palatal aspect. And so an adhesive bridge with a good diagnostic wax-up may suffice. It's definitely not the space for an implant, although it may look like it when you measure the buccal aspect. Sorry, it's frozen. There you are, next. So the green triangle outlines the different space measurements, and that's difficult. So orthodontics, my colleagues in orthodontics, all from all over around Sheffield, Lincolnshire, which is probably 60 miles away, send patients in. So hypodontia, although it's low in the population, in my practice every day, day to day, we see probably 10 a week, at least, patients at some time during the week, and new patients coming all the time because we are central for referrals. So you can see the lateral incisor space here itself is small, the canine's twisted, rotated, the central incisor mismatched, one's longer than the other, one's positioned slightly higher, and then you've got an ankylosed canine that's been surgically removed because they couldn't move it any further, and the other canine is also ankylosed. So none of these cases are ordered, structured, and most of the time when I talk to my orthodontic colleagues, I talk about car parking. In England, we have all these white lines for car parking in the correct spaces, and it only takes somebody to park over the white lines to prevent you from parking in the right space. And for implants and for prosthodontics, you need the right space for each tooth to be replaced. And as you can see, the denture tooth or lateral incisor is quite small because the canine's drifted far more forwards, but it can't be moved. So the questions come, do you accept the situation? Do you do something about it? Well, what do you do? In this context, do you remove the other canine, which is quite an aggressive treatment option because this patient's quite young, only 16. So decisions we make right at the outset are lifelong. And my hope is to keep the tooth life years as long as possible. And most of my time, I try and persuade patients to accept a compromised option whilst maintaining their teeth. It doesn't fit the ideal world, but it gives them something. And usually if they come from a denture that's not very good and unstable, they're accepting of the situation. But it's not always the case. So what the tools do we have? During this conference, I know that you've discussed a lot of issues like composite, lithium disilicate, sorry about that spelling, it's auto text, zirconium, gold, titanium. We have the same materials available to us all over the world. And osseointegration, that's evidence-based. Adhesive dentistry, evidence-based. There's no point in me explaining those things, but enamel is the best bonding. And if you can keep enamel, then you're doing very well. Conventional preparations I tend to avoid if I can. And my preparations are probably unconventional in the fact that they're very, very minimal. And I'll try and use the materials and extend the materials beyond their capacity just to provide some treatment. Obviously, removal prosthodontics are not ideal for a lot of the hypodontia patients. And orthodontic colleagues can move some teeth, can't move some teeth. And that's why I have clinics with them on a regular basis. And they get to a point where they can't move the teeth anymore. There isn't enough space. They can't increase the overjet because the teeth will look goofy, very rabbit-like. But we do have digital tools like intraoral scanners and CBCT scanners. Unfortunately, where we are, we do not have an intraoral scanner. And if you are going to purchase anything as prosthodontists, I would suggest you get an intraoral scanner. Digital is definitely the way forwards. In my practice, I have one, and it has made a huge difference. All those wax-ups that we used to do are now all digital. And I think digital is definitely the future for prosthodontists. So apart from getting some loops as postgraduate students, I would definitely invest in an intraoral scanner and software like MeshMixer, Exocad, InLab. And it's definitely a digital world out there. Sometimes missing teeth it doesn't look ideal from all the textbooks, but closing the space is sometimes much better than having a space opened to replace a missing lateral incisor, because the lifelong maintenance in this situation is so much better. Often we do things on a short-term basis for our own gratification because we're prosthodontists and we like to make everything look pretty. And this patient probably 15 years ago, if they followed the New York veneers chap, Rosenthal, somebody would probably cut all these teeth and put veneers on to make them look pretty. My belief is leave them as they are. Convince the patient that actually they look good, they'll maintain, they won't cost very much to maintain, perhaps bleach them slightly if they want to. But the fact that there's healthy gum and good natural teeth there, let's not ruin it, because that's what we can do as prosthodontists. We can accept these patients and try and do veneers. And my thoughts are, keep it simple, do nothing. There's no solution to provide, apart from advice. The radiographic space available sometimes, and this is the patient you saw with the pictures, the ankylosed canine. It's narrow. So there's no space prosthodontically for a tooth with an implant to go in there, given the direction. But when you look at the bone, oh yeah, that looks great for an implant, but actually the path of insertion of the implant into that bone would be very, very limited. So, when talking to our colleagues, the angulations of roots, the root morphology, and even the crown morphology have an influence on whether adhesive bridges will do well or not. Now, from my perspective, increased surface area for an adhesive bridge, that's a tick. I do not prepare any enamel at all, other than using pumice and water to clean it. And I generally do a wraparound, depending on the shape of the tooth, to try and get the best features of an adhesive bridge. So you can see here how the measurements are in terms of limitations of path of insertion. And I would say that these are quite tight. So my preference is, adhesive bridge. Adhesive bridges aren't popular, I don't think, in the UK, because everybody likes implants. Implants. And all the youngsters tend to do Invisalign and Align, Bleach and Blonde. So we spend 5 years training them as undergraduates, and they go out and do Align, Bleach and Blonde. That's as much as they want to do these days. It's fashionable, but real dentistry is completely missed. And it's a very, very sad state of affairs. When they write on their application forms, they want to help people. That's not what I envisage them to do. But this is the nature of the world today. And unfortunately, I'm too old. I'm old-fashioned. And I went to a conference the other day, educational supervisor, and I was told that the youngsters have a lot of value. And I have to appreciate it as an elder, that they have value. So I'm looking for that value from the youngsters. Thankfully, I have a lot of youngsters around me, and I constantly talk to them. I'm still not persuaded to change my values about treatments. Some patients with prosthodontic space, could be extended. When you're missing a canine and a lateral incisor, when you look at the size of the teeth, the size of the gap, the teeth are smaller. These are replacements, and the central incisors look large, but they want to keep the gap. Ideally, orthodontically, we want to close the gap so we can make more space for the canine and lateral incisors, but everybody's different. And you will notice a diastema in the lower jaw as well with a missing lower incisor. What do we do with that? At the end of the day, if the patient's got a gap in the top, leave the gap in the bottom. You're only going to do a composite, and the composite will stain. And if they're not bothered, I'm not bothered. Everything we see doesn't mean we have to fix everything. That's another nature of the students I work with. They'll see something and they always want to fix something. But there's a dialogue to be had with the patient, because I understand the students' excitement about doing an implant or fixing something or doing something, because that's the way they learn. But sometimes less is more. So I tend to go for less. The deranged occlusal plane. This is probably, when you look at this, I wish I could have a dialogue with all the students right now and say, well, what would you actually do with this? Given the occlusal plane, the compensatory dental alveolar compensation on the upper left-hand side posteriorly, limited space, it is actually a nightmare. But when you divide everything, you can rule. So what looks complex actually might be more straightforward than you think. So this is the same patient, and the clue is really in the first picture, their smile. The smile really gives you the go-to position of actually the incisal edge of the remaining upper central incisor is dictating that actually it's in a good position. So everything else must be wrong, or you build around everything else. So if we set the correct occlusal plane using this, then we can get a good diagnostic wax up to level as much as we can. Obviously, the upper left first molar is probably in the correct plane. So we're just building up the vertical dimension and evening out the occlusal plane. And I always start with a maxilla. And this is no different from the concept of digital smile design and makeovers, etc. They all call it cosmetic dentistry, but it's always been part of prosthodontics. It's just not called, cosmetic and align, bleach and bond and etc. This is just a fashion of marketing, a lot from the companies, because that's what they sell to us. So we sell to our customers, but actually it's just traditional prosthodontics. And setting the correct occlusal plane for patients like this does divide the top and bottom jaws, but it allows you to set it, and you've got to think about it like a upper denture. You set the occlusal plane. So these are all the prosthodontic things you already do, but you just have to apply it to a fixed situation. The other advantage of the situation, there's so many teeth missing, it's going to be more straightforward. Yes, you may need implants, but to set the occlusal plane will set everything in motion for you. Now, the only thing is when you're using an articulator here, try and spend time and get your face bow and dearticulate in the right position, because it's very easy to tilt the fork to fit the teeth, and so everything's angled at the wrong plane, and you want to try and actually get the correct plane. So sometimes I will use putty on the bite fork, and you have to stand in front of the patient and look at the occlusal plane, much like when you do an upper record block for a edentulous patient. So they're the tips I would use, but they're the skill sets that you already have as postgraduate students. It's just application. So you do have all the skill sets. You just need to know when to apply them and how. So this particular one is definitely divide, top and bottom. And I ignore the lower jaw initially because I focus on the top. Once I've focused on the diagnostic on the top, the lower will just follow. So this is a similar case of setting the occlusal plane. You can see the over-eruption or the deep overbite, particularly the lower left canine. The lower left canine here is significant, so there's no restorative space at all. So what do? We look at the smile line, we set the occlusal plane. I sometimes use a bite plane device and give the information to the technicians. Now in practice, I will just scan everything, send them the photographs and digital smile design, and it's virtually done. At this point in time, I'm not really interested in designing what restorations I'm going to do. All I want to see is the end point. And I will show the patient the end point. This is the architecture of planning. This is the model building. And then, once you've got the final view, you can then start thinking about how will you replace the missing teeth? What will you do? So should we do composites on the central incisors to increase the width dimension? Should we do an adhesive bridge from the upper right canine and upper left, upper right central? Do we keep the deciduous teeth and use them? Now, my tendency is don't extract deciduous teeth unless you absolutely have to. Always use the deciduous teeth. Until which time you have a plan. Now, once you create the space and the deciduous teeth become mobile, then you should have a plan for the replacement. So everything's working segments. Divide the top and the bottom arches, and you do this anyway, and then go through every space and what can you utilize. And the principle is keep it simple, do no harm. And if you do use composite, it's fine, because you can always replace the composite. It's very cheap. You're not actually damaging the teeth to do it. So it's my go-to material. And everybody has it. Coming back to more simpler solutions, these solutions, the orthodontist has spent a lot of time creating space. And this patient is something I've done 15 years ago. One of the postgraduate students actually did it under my supervision. And you'd think, well, actually, an adhesive bridge would probably be the best solution. And I probably would say that today that I would probably do an adhesive bridge. Whether you should do it single cantilevered or double cantilevered, the only issue is orthodontic retention. So kids coming through an orthodontic pathway, orthodontic retention is the key, because it is the key to our failures in prosthodontics, because when the teeth move, a single cantilevered bridge will always be out of place. The pontic moves and everything needs to be redone. The problem at this point is that what little space you have is lost. So you always need to be thinking about the future. In this particular case, we did try, these were fashionable at the time, 15 years ago, a one-piece implant. The only problem is that the direction of the bone and direction of the crown have to be in alignment. Otherwise, you can't use this. If the bone is proclined and the position of the tooth is at a different angle, then it's not really going to be possible. So you don't have any screws, and you just prepare the abutment surface with a high-speed handpiece under rubber dam, particularly if you're doing on the same day as the placement. But you can just put some composite over it as it is and wait for the gums to heal and then prepare it. And this was all done by a postgraduate who was excellent. And the outcome has been very good to date. Unfortunately, we don't see these patients year in, year out. They just come and go. So implant size limitations, well, what is ideal? Well, we have 3mm implants, but only if the axis is correct. and there are 2.4 mini implants. I don't now do implants for lower incisors anymore. I think they're quite too difficult. Their proximity to the adjacent roots is difficult as also. And then we have the fashion of new implants, new surfaces, etc. This is a machined implant in a hypodontia patient. The jawbone was thin, the grafting melted away, and you're left with this exposed machine surface. But the great thing is that we have other skill sets or colleagues with other skill sets in periodontology that can mask it all. And it can look from this to this. I've seen this patient 15 years on, and now that gingiva is now halfway down the crown. And I've harvested it again for another site. But machine surfaces are probably the best implant surface ever. I don't care about SLA, acid etch. Whatever we're provided with by companies, the machined is definitely the best. If we could go back to the machined, I would definitely do so. It has reduced complications with periimplantitis. So our advancement in ceramics and everything has allowed us to do some simple things. In some patients, implants aren't ideal and they're missing some teeth. And I tend to use adhesive dentistry quite a lot for hypodontia patients, particularly because they're quite young and we can always do implants later. But often hypodontia patients don't come with significant bone volume. Although the tissues look quite wide, I can certainly tell you that the bone is very, very thin and it would need significant grafting. We did try an implant in the upper right premolar region and it had failed, and the patient decided actually the sticky bridge was the best way to go. So you can see the x-ray, sorry about the artifact, the very short roots of deciduous teeth, but we kept the canines. And this is what we did in the lower. Now, if I can mill it out of Emacs, then I will. And I go beyond the guidelines because I know that Emacs we can etch, bond, and glue. And the success rate's quite good. It's just the strength issue. If we use zirconium, we try and create spaced areas where we add feldspathic porcelain, which we can then etch and bond. So they add a little bit of feldspathic on a fit surface. And these look quite good. Yes, they're bulbous. It's hard to define them because of the connectors, but from a conventional, simple, adhesive approach, I think this is much better. And this is one deciduous tooth on the right-hand side and a permanent canine on the left-hand side. And if you look at the spacing's not ideal, which is why the shapes of the bridge work aren't ideal either. And this is something we have to accept, that we may not do the contours that are ideal and we have to compromise. But the diagnostic wax up, setting the upper arch, then setting the lower arch is the key. And we do trial these in the patient's mouth often, get their agreement. They're usually very happy. And then the delivery of this is really straightforward. There's hardly any preparation. Try and keep as much enamel as possible on the teeth. The enamel is the best bonding. Also, if you prepare exposed dentine on these young pulps, then more inclined to be sensitive. And as you know, the more repeated injuries on teeth leads to pulpitis and root canal treatment and part of your pain pathway. And that's what the finish looks like. And it's again done by a postgraduate student quite simply, but it involves all adhesive dentistry. This is nothing, no implants in this particular patient at all. And as you can see, adhesive bridges, So we didn't use the deciduous canines. We used the central incisors. We've even veneered the front teeth. Not my ideal because of too many margins. Where there are more margins, you've got more to worry about. But at the moment, it seems like the best, simplest solution. Unfortunately, they will have to wear a retainer just to maintain the spaces, and often provide an Essex retainer because if they do have a debond failure, then they need to consider that as an emergency. Now, Paul King et al. From Bristol done a long study on the success rate of adhesive bridges. If you look it up, it's 80% over 5 years, 80% over 10 years. Actually, it's 80% over 15 years. That's very good. So this is my go-to tool for a hypodontia, if I can.
May I just interrupt, Dr. Patel? You have finished 40 minutes of your lecture. How much more time do you need?
I will go through them very quickly. It's just cases now.
Fine.
Okay.
Great.
So this is another case. Again, simple. This is a reverse zirconium bridge in the lower arch. This is one of my longest cases. Started at the age of 12, and I've done a composite bridge on deciduous teeth. Since then, he's had a SAMI as he's grown. So he's now 25, 26. You can see the change in shape of the palate. The teeth are somewhat larger. The jaw shape is not ideal, but it corrected the crossbite. And what you will see is I use deciduous teeth all the time. Use the deciduous teeth to the end. And then when they fail, I have plan B, plan C, plan D. The patients know that. So planning for you. This is another one where the deciduous teeth have failed, and the option to do both sides or one side, you know, at the end of the day, patients want things done. So I elected to take these out for them because they're in for occluded teeth. And this is all done by postgrads, I've got to say. And angling implants, another savior. And this is the finished result. So, you know, keeping it simple is good. So, learning points. Use your existing skill sets. Keep it simple. Consider all the options. Do less first because of life cycle costs and tooth life years. So utilize the value of deciduous teeth. Hopefully I've met those, and thank you for your attention. I know that you're running late, so I'm very privileged to be asked to be invited to speak, and hopefully I've contributed something to the education of the postgraduate students in India. So thank you for the organising committee for your kind invitation. Thank you.
Thank you, Dr. Patel. And it's been really a pleasure that we heard you yesterday and also today on the keynote platform. And one question comes to my mind. You said you would still go back to machine surface. Could you just comment on it?
Yeah, I've been fortunate. Sheffield was one of the first centres that did implants in 1985 with Branamark, who visited the place. I have seen lots of patients with machine surfaces over the years. They've never had peri-implantitis. The other thing about the process of these patients is they had their abutments fitted at the time of second stage surgery. They never had the abutments removed. So the hemidesmosole attachments around the titanium machine surface was stable. Even the single tooth Sarah 1s, I've never seen a problem. I've always seen a problem with all the roughened surfaces of all systems everywhere. So in our success of trying to bring everything forward and increase the numbers, the number that's missing is longevity and complications. Because when you look at the literature, the complication rates of implants are quite high, but people tend to cower away from telling patients this. So I've seen with my own eyes because I've been in the same place 24 years. And that's another good learning point for the postgraduate students. See your own mistakes, stay in the same place, don't move so often, and then you will really learn.
I don't think that would be to anybody's liking, but coming from an experienced man, I think we should learn from this that your mistakes are your own teachers. And I liked your statement that you are a specialist in everything and expert at none. It's your humility to say that, and I'm sure the postgraduates make a note of this, that it is a dilemma for any prosthodontist PG student that, considering the vastness of the course and the range of treatment options we have, I'm sure it's a challenging job to be an expert in everything. So thank you, Dr. Patel, for keeping it simple. Like you said, you want to keep everything simple, and I think that's the value point which you gave us. Thank you so much.
Thank you.
And thank you for accepting our invitation. And it's a pleasure. And like I said before, we want to see you in India sometime soon.
I look forward to it, and it's my honor to be invited. So I'm very much honored to be invited. So many thanks to all of you, and stay safe.
So we're just displaying your certificate just for posterity's sake, and it will reach you sometime soon. Thank you so much, Dr. Patel.
Thank you. Cheerio, everyone.
Thank you, sir. Thank you, Dr. Omkar Shetty, for sparing your valuable time and chairing this session. Please accept this token of appreciation from our side, sir.
Thank you.
Thank you, sir. Thank you, Dr. Narendra Pariyar, for chairing this session. Please accept token of appreciation. Thank you, sir.
Thank you so much.
We shall move on to the next session now.